This session is about the Smart India study. So this is something that we had done. A few centers in Kerala, Little Flower, Giridhar and Tony's were part of the center, and there were 20 centers involved. So we had done, we had started the study in 2018 and it wound up by 2021. And it's about our population and our data. So that is something that I wanted to, project. And so I sounded it to Dr. Mahesh first, and he was very enthusiastic about it. And so I'm grateful for that. And so we are all here, and we'll discuss the Smart India study. The first speaker is Dr. Juhi. Dr. Juhi is an associate consultant at Giridhar Eye Institute. She completed her medical retina fellowship from the same place. She's also a young and keen researcher with a few publications under her belt. Dr. Juhi.
Thank you, ma'am. Thank you for this wonderful opportunity. So I'll be just talking about the protocol and study design of Smart India study. So as we know, the number of diabetics in India is on its rise. 77 million documented in 2019. It is predicted to increase to 135 million by 2045. With such high number of diabetic patients, it's difficult to screen each person individually for the complication of diabetes like diabetic retinopathy. So what we need is a risk-based strategy or a screening pathway which will help us to identify those people who are at risk of visual impairment due to diabetes. Smart India study is a multi-center effort to actually deal with this particular problem. So Smart India study was part of the Ornate India project, which is a UK-India research collaboration, which is funded by UK Research Innovation and GCRF, that is a Global Challenge Research Fund. Global Challenge Research Fund was started by UK government in 2015 with the primary aim of dealing with global challenges across low and middle income countries. So the main aim was to build research capacity and capability in India and UK to tackle global burden of diabetes-related visual impairment. It was a multidisciplinary, multifaceted UK-India study, which was led mainly by Dr. Shobha, who's a retina consultant professor from Moorfields Eye Hospital, and the team had ophthalmologists, diabetologists, public health experts, primary care physicians, research scientists, biostatisticians, computer engineers, both in UK and as well as in India. So to make it or to deal with all aspects of diabetic retinopathy care, Ornate India project had divided it into 5 integrated work packages. And the work package 1 was the Kerala Nayanamritam study and the Smart India study, which dealt with evaluation of screening models for diabetes, pre-diabetes and diabetic retinopathy. And other work packages included utilization of AI in retinal image grading, using biomarkers in identifying sight-threatening diabetic retinopathy, health economics and risk modeling. So Smart India study was put forward to translate research evidence into clinical and community practice. The primary objective was to determine ideal test that could identify people at risk of diabetes. Second was to evaluate if an initial triaging with non-lab diabetic risk score, which is more effective than using directly the conventional lab test. And third was to develop an affordable, easily deliverable and clinically effective model to identify people at risk of complications. Other objectives included to build future policies on screening of diabetes, to identify the regional prevalence, and to find out the accuracy of AI in diabetic retinopathy grading. It was a multi-center cross-sectional study which was conducted between November 2018 to March 2020. It recruited participants from community-based screening so that it can accurately identify people who are at risk of diabetes and pre-diabetes. So it covered around 20 sites across 10 Indian states and 1 union territory, and each region was again divided into 3 categories, so 3 clusters: urban, rural and a special category, so that it will give broader representation. The special category was a group of people who had limited access to healthcare or who were considered to have low or high risk of diabetes. If you see the map, you can see most of the centers were in South India, and this was because of the increased prevalence of diabetes in South India. The study was performed as a door-to-door survey with questionnaires and point-of-care test performed by field workers. Stratified sampling was done using data from 2011 census, a census enumeration block covering 125 to 150 households in urban area and villages or rural area covering approximately 300 households. Each household was approached and inclusion criteria was adults who are 40 years of or older of Indian origin and vulnerable population, those who are currently participating in other studies or people with type 1 or secondary diabetes were eliminated from the study. So as we said, it was a questionnaire-based study which was done by field workers. They approached the household, obtained informed consent, unique patient ID was given to each participant, and a detailed questionnaire was given which included demographics, brief history, anthropometric measurements, socioeconomic status, and other parameters. And the people were divided into two groups. One was already known diabetics and the other where diabetic status was unknown. In diabetic status unknown category, if HbA1c was more than 6, RBS was more than 160 and 50 participants per cluster of RBS between 110 and 159 were subjected to further test. And the further test includes lipid profile, microalbuminuria, non-mydriatic ocular examination including visual acuity, non-mydriatic fundus photography using a retinal camera was also taken. And the fundus images obtained were actually uploaded into a teleophthalmology cloud drive, which were then graded by a primary grader from the local center and a secondary grader from another center. And if there was any disparity between these two, it was also consulted by a senior retina consultant from the second center. It was the responsibility of the local center to identify the grade of diabetic retinopathy and give them adequate referrals. Like if it was a sight-threatening diabetic retinopathy, it were referred to eye hospitals. Non-sight-threatening diabetic retinopathy was asked to visit the retina consultant after a year, or no diabetic retinopathy, no further action was necessary. So to conclude, Smart India study is the first population-based prospective study with pan-India representation, risk-stratified, resource-efficient screening models are given by this study, which will help implement targeted screening or targeted interventions in people with diabetes. This will help us to identify diabetic complication and to mitigate blindness due to diabetes in India. Thank you.
Thank you, Juhi, for the protocol that you've elucidated. And
next, we'll have Dr. Mahesh Gopalakrishnan talking on national prevalence of diabetic retinopathy and blindness in known and unknown diabetes and economic implications. I've been asked to introduce Dr. Mahesh. I don't think he needs an introduction in Kerala. That is Dr. Mahesh Gopalakrishnan.
Good morning, everyone. Actually, 5-6 months back, Sheena called me and asked about why don't we have a symposium on, it is not an instruction course, it's something like a symposium on Smart India study. So I said that is a very good idea. In fact, we quote all the other studies like DRCR, NET, DR, this, that and all. Our own study, this is a huge study done in India, and which has, only if you cite it and quote it and then understand it, then only the value of the study goes up. So everyone should understand, at least they should have some knowledge about such a study is there, and we should quote it everywhere regarding the prevalence and incidence and all this stuff. So that is why we wanted to introduce this. It's a complicated study, I know, but after each talk, if you get 1 or 2 points from that, it will be very useful. So it's a very, and we are fortunate to have Dr. Rajalakshmi, who has put her mind and everything into this study and then published more than 20 articles. No? How many? Yeah, so many articles. And just see this. This article was published in Lancet Global. So I am talking about 2 studies, 2 articles. National prevalence of vision impairment and blindness associated risk factors in adults aged 40 and older in known and undiagnosed diabetes. So this is a result that I am going to talk initially. So this was published in nothing other than Lancet. So that is the importance of this study. So already Juhi has mentioned the outline of the study, how well it was conducted across India in different groups with a good representation across. So till now we have only some old data like rapid assessment, avoidable blindness methodology data, all these data are there, but we don't have much of a details on undiagnosed diabetes also. And so that is why the aim of the study was to report the national and sub-national, the regional prevalence of blindness and vision impairment in known and undiagnosed diabetes. So let us go through some of the salient features. Why this study is important is, this gave the national prevalence of vision impairment and blindness among people with diabetes as 21.1% and 2.4%. This data is very important. So prevalence of vision impairment and blindness among people with diabetes. So just remember few numbers. That is all that is required. And the importance is undiagnosed above 40 randomly people were checked for HbA1c, and they also were included in the study if HbA1c was more than 6.5. All the protocols were kept, ICMR guideline, approval. It was a 20-center cross-sectional study, one area in each territory across India, and all individuals older than 40 years staying in that place for 6 months were included, and all diabetics, and randomly lot of non-diabetics also. So HbA1c was checked, and with a random sugar point of care kit, and diabetes was defined as more than 6.5 in undiagnosed diabetes. And vision check was done using a smartphone based app, and non-mydriatic fundus camera was taken for fundus evaluation also. Huge number, all participants, more than nearly 8,000 people with non-diabetes and undiagnosed diabetes were there. And these are some data. It's a very complicated study. In fact, to understand the whole thing, you have to read it at least 10 times repeatedly. So I will go through some of the salient features. By extrapolating the study results, prevalence of vision impairment is 21.1% and blindness is 2.4% in this group. That is one thing. So these were similar in that vision impairment and blindness were similar in undiagnosed and non-diabetes. That is another finding. That is people already non-diabetic and undiagnosed, that was diagnosed by blood test. So, and older age, lower educational attainment and unemployment were more related with this. Manifest signs of low socioeconomic status such as underweight BMI associated with vision impairment. So some few points which all of us know, but just remember the numbers. So there were lot of patients with ungradable retinal images due to cataract. So that is the importance of, still cataract is a important cause for vision impairment even in diabetic patients. So that is, so reducing cataract burden itself is a part of managing diabetic retinopathy, preventing diabetic retinopathy blindness. That is one other important outcome that came from this. And there is something called epidemiological transition level states. India is divided into different epidemiological ETL states, and based on that also some analysis was done. I will come to that. The important strength of this study is nationally representative data set and a large sample size, and absolutely perfect statistical weighting to ensure national representativeness. Cross-sectional nature is, as any study like this, it will be cross-sectional nature. So there are some limitation, and it did not recruit people younger than 40 years. So, and some patients with type 1 diabetes may have been included. Some small things, but it is quite okay. So in conclusion, the 2011 census data we used underestimated the rates, because population also has grown over the last 10 years. Secondly, non-mydriatic retinal imaging was done, which underestimated the rate of diabetic retinopathy. And already blind people may not have been included in this study. So that is, these are a few things that are concluded. This study showed the prevalence of vision impairment in type 2 diabetes in India, especially low socioeconomic status. This is the take-home message in this. Now, the second study is prevalence of diabetic retinopathy stratified by known and undiagnosed diabetes and socioeconomic indices. This is the other part which was published in Lancet later. So I will just go through a few salient features in this also. Here, what is called epidemiological transition levels. Actually, in India, different ETLs are there based on the database. And high ETL means the non-communicable diseases are high. South Indian states are high ETL, right? South Indian states, unlike North Indian states. And this study analyzed the rates depending on the ETL, epidemiological transition levels, and socio-demographic index. So these two studies were taken. Parts were taken. So ETL is the ratio of all dailies due to communicable, maternal, neonatal, etc., etc. It's due to versus non-communicable diseases. High ETL state like Kerala have high non-communicable diseases, and SDI is expressed on a scale, and that is also I explained. So these two factors they analyzed in this study, and primary outcome variables were diabetic retinopathy and vision-threatening diabetic retinopathy status. So number of people with VTDR, vision-threatening diabetic retinopathy, was also. So the value of this study is it showed that the prevalence of 12.5% for diabetic retinopathy and 4% of vision-threatening diabetic retinopathy. These two values, just remember. So that is it found the value like this, and it is low SDI and epidemiological transmission level has lowest prevalence. Just like high, that means if the non-communicable diseases and high ETL states have higher prevalence, and this has importance in the allocation of funds. So it's as already explained, it's a multi-center study, and trained field workers have done all the this thing and screening of diabetic retinopathy, and these are the number of patients included in the study, and already that the methodology has been explained. So high and middle ETL states and have 3 to 4 times higher prevalence of VTDR than their counterparts. Secondly, they generally increased with age, and thirdly, non-diabetes approximately double observed in those with undiagnosed diabetes. So these are some of the findings. The prevalence of diabetic retinopathy has been always reported to be lower than global prevalence. In this study, 3 modified risk factors were identified: hyperglycemia, hypertension, and albuminuria. So in Kerala also, different projects have been launched. The strength of the study is very large sample size, and probably cross-sectional study is a drawback. In conclusion, the burden of VTDR is insignificant. It is significant. Future policies should consider the heterogeneity of VTDR burden, and fund allocation should be based on the ETL. So these 2-3 points, the incidence, prevalence of blindness in and vision-threatening diabetic retinopathy, please remember, and quote Smart India study everywhere possible. Thank you.
Thank you, Mahesh, for the effort you've put in. It is important because this study has a pan-India representation. Most of the other data that we have, Indian data, most of them are restricted to South India and few pockets of India. So that is why this was a very relevant study. So we'll move on to the next talk. So it's my honor and privilege to introduce Dr. Rajalakshmi to us. I thank Dr. Thomas Cherian for suggesting Dr. Rajalakshmi's name, because initially when I thought of this IC, I honestly didn't have her in mind, but that is my loss anyway. So Dr. Rajalakshmi heads the medical retina department in Mohan Eye Center in Chennai, and can you ask them to put that slide? 13B. She also heads research in the same institute, and she's got a passion for ophthalmic research, and her main interest is cost-effective screening for diabetic retinopathy. And her focus of interest is retinal imaging, teleophthalmology, and artificial intelligence in various retinal diseases. She has been the principal investigator and co-investigator in many international projects and collaborated with a lot of eye projects. She is also a section editor in the Eye Journal of Medical Retina and a prolific publisher. She has over 70 original articles to her name, and it is really an honor to have her here and help us understand what we can take home from this study. We all know it's important, and the papers were very difficult to read and comprehend, but since Dr. Rajalakshmi has been in the entire thing from the beginning, so over to you, Dr. Rajalakshmi.
Thank you, Dr. Sheena. Thanks for your kind introduction. And at the outset, I would like to thank Sheena, Dr. Sheena, for inviting me, and Dr. Thomas Cherian for suggesting, and Dr. Sheena for inviting me for this excellent academic session. It is true that the Smart India study happened involving all the doyens of ophthalmologists across India, and it is a study which has not been discussed enough in any of the ophthalmology conferences in India, and thanks for initiating this. I have no conflicts of interest or financial disclosures. As Juhi rightly said, Dr. Shobha Shivaprasad is also from Kerala. She did her MS ophthalmology in Kerala only, and then she moved on to Moorfields, and she got us this 6.3 million pounds grant, and out of which we got about 20% coming to India, which helped us do this study. Work package 1, Smart India study, is what we are going to be talking about in this session. Juhi has already shown this nice map of 20 sites which were involved in this study. And this was a study which did a cross-sectional population-based study. It's easy to do a clinical study. Doing a population-based study is not easy at all. To study the burden of diabetes as well as diabetic retinopathy across the country. It was also to assess regional-wise prevalence of the different complications, including retinopathy. So this is the protocol which Juhi explained so clearly. So I can skip this slide and move on to my topic, the burden of undiagnosed diabetes and suboptimally controlled diabetes and the associated risk factors. So in this Smart India study, it was conducted in people above the age of 40. And what was done was, a one-touch glucometer. So by the one-touch glucometer, if they had diabetes, the blood values were noted. If they had one-touch glucometer value of above 160, many of you may have people at home with diabetes who have a one-touch glucometer at home. A new thing which was used was usually HbA1c or glycated hemoglobin is done by blood test from a venous sample. This was a study which used a point of care kit, which is so simple and easy to use that even at the home they could check the 3-month average sugar control, that is the HbA1c or glycated hemoglobin. And if that was above 6.5 also, that also turned out to be a way to diagnose HbA1c. Okay, so this is a pictorial description. They took how the field workers were so actively involved. They took the anthropometry measurements, they checked the blood pressure, their weight, height, and then the random blood sugar. And then there was, if they did not have diabetes, they were just given the parameters. They had diabetes, then they underwent all these tests. You can see the A1C. This is a point of care kit. This was again a point of care kit to analyze the lipids. And those who had retinopathy, they were told why they are going to undergo a photograph. They used a simple handheld camera and took pictures of the patients in their own homes. We all struggled to take pictures in the hospitals. These were pictures taken in the homes. And you can see that in the Smart India study, there were already about 5,689 people who declared that they had diabetes. But through the study, there were again 2,221 people who were identified to have diabetes, who did not know they had diabetes, and they were newly diagnosed to have diabetes through the study. So I'm going to take you through these results. Because when we speak so much about India as the diabetes capital, it is not something to take pride of, but we have to remember that it is a big burden to have a non-communicable disease like diabetes, because that will lead on to other complications affecting all parts of the body. So in this, what we found in particular was, earlier we thought that diabetes can affect only the urban people and rural people are not affected. We were right in the sense that known diabetes was higher in the urban areas at 17%, and rural areas it was only 9%. Whereas if you look at undiagnosed diabetes, the percentage of undiagnosed diabetes was 6.1%. If you see 2,200 people out of the 7,000 people, which means 30% of the people did not know they had diabetes. If they don't know they don't have diabetes, if they did not know that they had diabetes, how will they have their eyes checked for retinopathy? How will they go to the ophthalmologist for further eye assessment if they don't even know they have diabetes? And what is important to us as South Indians, people from Kerala and Tamil Nadu, is that the South has the highest prevalence of diabetes. See, 19% of known diabetes, 7.8% of undiagnosed diabetes, so 25%. We had the highest prevalence of diabetes. So we need to be, the government of India has to give more importance to the south states where the prevalence of diabetes is higher. So if you look at the risk factors, we are all aware of these risk factors. Again, obesity being an important risk factor, increasing age being important risk factors. Dr. Mahesh told about the ETLs. That is the better to do states like Tamil Nadu, Kerala, Karnataka, the better doing states. The better doing states have more of diabetes, more of hypertension. So people at the higher ETL states had higher risk for diabetes and other things. Again, higher cholesterol levels. These are all added. But what is important for us to know is how is the sugar control in our patients? Whenever our patients come for cataract surgery or they come for diabetic retinopathy assessment, we check the HbA1c. But what is their control like? We talk to them only when we found that randomly in the study, only 25. Normally, we all know that less than 7 HbA1c is considered to be good. When it goes above that, poor control is above 9. Only 25% of the people, whether it was urban or rural, had a good HbA1c control of less than 7. More than 40% of them had high HbA1c, which is which caused retinopathy. Here you can see that when the HbA1c is above 7, the percentage of retinopathy goes odds is 16%. When it is above 9, 21% had retinopathy. Even the vision-threatening retinopathy goes up, increases by 4 times higher risk for sight-threatening retinopathy when the HbA1c is above 9. That's the importance of glycemic control. So if you see that in this study, what we found is any person with diabetes, BP should be less than 140/90. LDL should be less than 100. We say when there is macular edema, HbA1c, only 25% had HbA1c less than 7%. Irrespective of the age, whether it was rural, urban, male, female, HbA1c control was very poor. We have very poor glycemic control in India, which is a very sad state of affairs. It could be that there's lack of exercise, everybody is seeing the mobile, no physical activity being there, etc. If you look at even people with longer duration of diabetes, their control only 20% had good glycemic control. In fact, even illiterates or literates, everybody HbA1c was quite bad. So poor glycemic control is a major risk factor for all microvascular complications, kidney disease, heart disease, retinopathy, everything. So to conclude, the prevalence of diabetes is 18%, known diabetes is 13.5%. The prevalence is highest in South India. The prevalence of diabetes is higher in men. Known diabetes prevalence was higher in urban areas. 30% of them did not know they had diabetes, whether it was urban or rural. 75% of the participants had suboptimal glycemic control. 40% of them had very poor glycemic control, HbA1c greater than 9%. These are the patients whom we treat. And it is important to emphasize glycemic control to reduce the burden of diabetic retinopathy. Thanks for your attention. And I would like to show, this is the Smart India team. Of all of us here, you can see Dr. Sheena here, Dr. Shobha Shivaprasad, and all of us here, the team which was involved in doing the Smart India study across the 20 sites. Thanks for your attention.
Thank you. Thank you, Dr. Rajalakshmi, for that wonderful talk. You made it very simple and very easy for us to understand. I'd like to call upon Dr. Thomas Cherian. He is the president, KSOS. He needs no introduction in our setting. And I'd like to thank him for coming on board and encouraging me in this endeavor. Dr. Thomas.
Good morning, and thank you, Sheena. I was faced with 2 challenges when Sheena asked me to do this. First, of course, we really enjoyed doing this Smart India study, being part of the study, picking up data, collecting and collating data and all that. But once these reports came out, it all sounded Greek and Latin. And I've been reading these reports over and over again for the last couple of weeks. Still, I have a lot of knowledge lacunae in this. That is the first challenge. And the second is Dr. Rajalakshmi is a live wire in this study, and to speak after Dr. Rajalakshmi is even more challenging. Anyway, I'll try to do my best. We again discuss about two articles. One is sight-threatening DR and the need for risk-based stratified screening. Diabetes and its complications lead to common causes of morbidity and mortality globally. And the low-income and middle-income countries are the most affected by this diabetic epidemic, and there's a large unmet need to screen for pre-diabetes and diabetes in our country, where primary healthcare is underdeveloped and the laboratory tests are costly. I'm not speaking about Kerala as a state, but of India as a whole here. The objective of the Smart India study was to evaluate the risk-based stratified screening models for diabetes and its complications, and to develop and apply statistical and economic models to personalize screening approaches, optimizing resource use in India. The research questions were: how can risk-based stratification improve the efficiency and outcomes of diabetic screening in India? What is the economic impact of different screening strategies for diabetes and its complications? And how can personalized screening reduce the burden on healthcare systems while ensuring optimal health outcomes for the individuals? As far as WHO is concerned, these have all been discussed. We have symptomatic patients above HbA1c is 6.5 is considered as diabetic. And normal HbA1c is less than 6, and anything more than that is either pre-diabetic or diabetic. And despite its variability, random blood glucose is the most common blood test done in a mass screening program even now. But if we have the more convenient point-of-care HbA1c kits which are now available, it shows a good correlation with laboratory-based HbA1c estimation. Approximately 30% of people with diabetes present with macrovascular complications such as cardiovascular, cerebrovascular, and chronic kidney disease. There is no systematic screening due to economic constraints, paucity of public health programs and inadequately trained manpower. We identify sight-threatening diabetic retinopathy with images either manually or with artificial intelligence, and retinopathy screening is done with handheld cameras, which is an efficient and cost-effective screening option. These were the centers which was shown earlier. The study design and methodology was a multi-center approach, a risk-based stratified screening. We had a statistical modeling using advanced statistical models, and to make it cost-effective, we have had an economic modeling also, universal versus targeted screening. The three objectives, we were trying to look at ideal tests that could identify people at risk of diabetes and pre-diabetes, and found that a point-of-care HbA1c levels evaluated were comparable to or even statistically better off than testing a random blood glucose. Now, the circulating biomarkers for assessing sight-threatening diabetic retinopathy, we try to identify circulating biomarkers. The previous discovery and verification studies have reported a selection of circulating biomarkers with good diagnostic power to identify those with STDR. And this was aimed at evaluating previously verified blood biomarkers using ELISA for their potential usefulness as indicators. The main goal was to evaluate the diagnostic performance of these biomarkers, and the research questions were: can circulating biomarkers reliably identify individuals at risk for STDR? HbA1c, glomerular filtration rate were all measured in hospital laboratories, and the samples were anonymized before transfer to the laboratories. The selected biomarkers, these were the selected biomarkers which were studied, and cystatin C and leucine-rich alpha-2 glycoprotein 1 were the ones which ultimately mattered. Sensitivity analysis was carried out to compare the area under the curve of closely related biomarkers, serum creatinine and cystatin C, and in addition, cystatin C levels were compared between STDR group and no DR group with normal kidney function, as elevated cystatin C levels may be attributable to diabetic kidney disease rather than sight-threatening diabetic retinopathy. This was the analysis of the expression patterns in the UK part of the study. Cystatin C at the addition of cystatin C to the base model yielded an area under the curve of 0.779, and leucine-related alpha-glycoprotein to the base model yielded an area under the curve of 0.763. when it was extrapolated or when it was studied in the Indian arm of the study, again these two, especially cystatin C, was the significant biomarker which we identified in the India arm of the study. In the UK population with estimated prevalence of STDR relative to no DR is of 6%, that means if 1000 people with no diabetic retinopathy or sight-threatening diabetic retinopathy undergo retinal screening, 60 out of 1000 would be identified as having STDR. While if you take those cystatin C positive people, then 274 out of 1000 patients would be classified as STDR. In the India part, when cystatin C was used, 115 out of 1000 were picked up in the India part against 52 without the screening with the biomarker. When cystatin C levels were added to age, again an area under the curve of 0.779 compared to 0.735 without cystatin C was obtained in the UK. The validity of this strategy was similar in both UK and India. Therefore, the results suggest that the biomarker was useful in both the countries. Now, the strength of the study, both the India and UK models achieved close to acceptable discrimination. Second, the models relied mostly on routinely collected data except for cystatin C. However, a point-of-care cystatin C biosensor may be accessible as a web-based application for self-monitoring by the patients. And data for cystatin C used in our final model did reflect as seen in our literature. Now we had a few limitations. That's pooling of samples from UK and India were not entirely possible due to logistical reasons. The validity of cystatin C point of care kit is needed before use in a healthcare or community screening setting. And serum cystatin C has also been shown to be an early marker of diabetic kidney disease. That means those with diabetic kidney disease also have a higher prevalence of sight-threatening diabetic retinopathy. To conclude, this is a promising diagnostic tool to have circulating biomarkers for picking up sight-threatening diabetic retinopathy. We need future research with additional multicenter studies, and we need clinical integration. Once validated, biomarker-based testing could provide a valuable supplement to the existing models. Thank you.
Thank you, Dr. Thomas. It's very interesting to see how even we all know that retinal imaging is the gold standard for DR and to detect DR, to screen for STDR. And it's interesting that a simple blood test could also help us point us in that direction. And even assessing risk factors alone without a fundus examination also could help us point towards STDR. So I think the final take-home points Dr. Rajalakshmi will elucidate towards the end, and we'll move on to the next talk, which is artificial intelligence.
Meanwhile, Sheena Lismani is a consultant vitreoretinal surgeon at Dr. Tony Fernandez Eye Hospital in Alua. And as we have seen here today, she was the person who was instrumental in bringing together the Smart India study to be discussed in our conference. And congratulations, Sheena, for that, and we are looking forward to your talk.
So my topic is artificial intelligence. That's the new buzzword everywhere, not only in diabetic retinopathy. So there were 2 articles published under the umbrella of the Smart India study. So I'll just go through that. A disclaimer, because there's a lot of research and there's a lot of work, and I've really not gone into everything. So these are the only 2 papers that I will be talking about. So we know that existing screening methods are, today how we screen for DR and STDR are either by a trained ophthalmologist or a desktop-based mydriatic retinal imaging, and then we grade the DR severity and then treat accordingly. However, both these methods are very resource intensive, and in our country where the numbers are huge, there are many challenges. We have a large number of sight-threatening DR alone, forget about DR. And with compared to the numbers of STDR, the personnel that are trained for detecting these are fewer. The infrastructure is not very adequate, and it's not uniformly distributed throughout the country. And even risk factor models, like Dr. Thomas had discussed earlier, is not ideal when compared to an actual DR fundus imaging. So how do we go about this, and what's the way forward? We would like to have low-cost portable cameras which could be used in a community setting. That would be the best way. And if the entire process of detection and screening could be automated, that would be very good given the population and the numbers that we have. So low-cost portable cameras, they are usually non-Midriatic, and they are handheld with no stabilizing platform. So they can be challenging to get good images. Even if you go with a camera, the images may not be very perfect, or it may not be good enough to even grade what stage of retinopathy the patient has. And invariably, the patient may have, these are little elderly, they have comorbidities like a small pupil and a cataract. We faced that challenge during the Smart India. We were not getting good images to even grade. And as the literature suggests that gradable images in a non-Midriatic camera is only 70 to 75% versus a dilated image. So increasing the gradable images is imperative to detect STDR. So coming to the second method of automating DR screening, again, the first step is to get gradable images. Only once you get good images, then only you can grade it. So that is usually the work work done by the person on the field. They will have to assess whether the image is gradable or good enough to even be uploaded to a reading center. And then only the next step comes is the actual grading, but before that we need the gradable images. And then of course the final step is actually detecting STDR, which is done by the ophthalmologist. So the two papers under the Smart India umbrella was, the first paper discusses about how a deep learning model was developed to be incorporated in the non-Midriatic portable camera. So it's basically a device which helped the field worker get good images. The field worker is not a trained ophthalmologist. They are just trained to go in and get images. So they should know, is this image good enough to be uploaded or not? That is what the AI and the deep learning model was taught to do. And the second paper was, again, the deep learning model could identify sight-threatening DR from these images. So these are the two papers. Both were published in scientific reports, one in 21 and the other second in 23. So the rationale was, deep learning model can, at acquisition, that is incorporated in the camera, can increase STDR detection rates, and whether these models can classify the gradability. It's not whether these models can grade the images, whether they can just classify whether these images are gradable or not. There's a subtle difference between the two. So this was between August 2018 and 19. December 2019, there were 20 sites involved, and the images obtained were by field workers. They were trained over 1 or 2 days. That's all the training that they had, and to capture these images. And there were 2 images taken from each eye. One was disc center and the other was the macular center. And there was no limit on the number of images, because basically we wanted to increase the gradability of the images. And then it was classified as whether these images were gradable or not. So the deep learning model, how was a sample was created from these images, and then that was given to train the model. And then this model, that is the model was compared to an ophthalmologist, how it was compared, how good the gradability of the images were, and the small model was also compared to a large model, that is a desktop-based camera. So these are the 3 things that were assessed in this paper. So what was the definition of gradability? At least less than 50% of the image is obscure, that is more than 50% should be seen, and more than 50% should be clear, and the entire optic disc should have been captured. So that is what is termed as a gradable image. So when they compared, this is the compact model is the one that goes into the portable camera, and the large model is one that is on the desktop camera. So when they compared both the models, both were reasonably all right, with the area under the curve of 0.96 and 0.97. Only the smaller model took a little more time in assessing whether the images were gradable or not. Again, both these models were compared to one grader, the grader 1, who was a trained ophthalmologist, and that again was fairly all right. And again, there were two graders involved. The intergrader agreement was also acceptable. So what this concluded was one can incorporate compact deep learning models to classify whether these images are gradable or not. So that is the first step that we have in the whole automation process. The second paper, the aim was again to develop a system to actually grade or point out referable DR. So which of these patients need to go to the hospital, which of these eyes need further treatment. So that is to identify referable DR, and then again to compare the accuracy of this to risk-based models. So what do you mean by risk model is, you identify all the risk factors, you know that all these risk factors are there, and so such and such patient is highly likely to have VTDR, versus just a fundus screening, and is that, which is better, are both equal, is what was the aim of the study. So again, the same process. There were two images that were uploaded onto cloud server and graded, again by the primary, secondary. If they differed, it was by the arbitrator. And then divided into two categories, referable or non-referable. Referable was either moderate to severe NPDR or PDR, or referable DME. So, and then the model was developed. It was by a deep learning method where the model was fed all the images and they were able to identify what was referable. So this was the entire process in a picture form. And so then it was the ability to predict referable DR and DME from these handheld cameras were assessed, and it was fairly good. The ideal way would be with both the fields, but even with single field inputs, the area under the curve was fairly good. And when assessing risk factors of individuals, like duration of DME, when all the risk factors were assessed, the duration of the diabetes was the most predictable to point to whether a person may have STDR or not. I'm not going into this. So this again is the same thing. Both the fields, if you have a disc-centered and a macula-centered field, would be the ideal way. But any of these frames could capture reasonably well presence of STDR. And if you assess all the risk factors, again, duration of diabetes is the most predictive for STDR. And to conclude, both these papers together, compact DL models can effectively classify non-mydriatic handheld retinal image gradability in the community setting, so that each word is important. It's not, a trained person is not going into the community and getting the images done. And also, we developed a deep learning system that detected referable DR from retinal images using, again, handheld non-mydriatic fundus camera by non-technical field workers. And the image-based outperformed all the risk factor-based models. So at the end of the day, ideally, a retinal image would be the best way to identify STDR. However, even risk factor-based models also work, but not to that extent. And thank you for the opportunity. And with this, we'll move on to the last talk. I think that is something that we all are waiting to hear, for Dr. Rajalakshmi to sum up all these studies and tell us what we need to take home at the end of the day.
Thank you, Sheena. I'm not very sure whether all of us have simplified this or confused you more. Anyway, we'll have the maestro here, Rajalakshmi, to decode whatever is there in Smart India study and give us some take-home points. Over to you, Dr. Rajalakshmi.
That's very modest, Sain. I know that it has been a team effort in Smart India. It has not just been involving all these 20 sites, bringing them together. It has been a great teamwork, and if teamwork continues, we'll have more such studies coming out like the Smart India. And coming to these take-home points, see, we are all have to work together because India right now has over 100 million people with diabetes, and blindness due to diabetic retinopathy is preventable. So these are the things that we want to know how Smart India, what Smart India has, the lessons that we can learn from Smart India. In Smart India, we did not want to look at national prevalence of diabetic retinopathy or diabetes. We wanted to know what is the most cost-effective model, what is the most accurate, simple model which can be used to detect diabetes and diabetic retinopathy. So this possibly is the first study. There has been the S&DREAM study, there has been the KSOS study, but this is the first study on national prevalence of diabetic retinopathy, which involved 4 main centers, 20 hospitals across India, with doyens from each and every center who participated as principal investigators to assess the burden of diabetic retinopathy. It is not easy without the cooperation from all these people who have their own patients practice to get involved in such a major study with such a large sample size across the country. See here, you can see the names of all the big people who have been involved in this study, and this also led on to the India Retina Specialist Group, which also got involved in doing more studies over the course of time. So what is the main point that we came to know from the diabetes thing is that 30% of them did not know they had diabetes, and even those who had diabetes had very poor control. 3/4 of them had suboptimal glycemic control, which is the most important factor other than duration of diabetes for developing vision-threatening retinopathy. So from the diabetic retinopathy paper about which Dr. Mahesh Shanmugam spoke, Dr. Mahesh Gopalakrishnan spoke, was that the prevalence of diabetic retinopathy in India, because we say more than 100 million people have diabetes, 12% itself means that there are 13 million people with diabetic retinopathy and 4 million people with vision-threatening retinopathy across India, which is, and we don't even know how many of them have actually met the ophthalmologist. So to look at some of these points, we see that undiagnosed diabetic retinopathy is 8%. So many people who don't even know that they have retinopathy, so they have not gone and met an ophthalmologist to get their eyes checked. So 4 million people with sight-threatening retinopathy is a big problem, and you can see that both urban and rural. Earlier we thought diabetic retinopathy also occurs only in urban people, but we find that here in rural areas also retinopathy is as highly prevalent as what it is in urban areas. After the Smart India study got over, there was in fact questionnaire shared with the Smart India population because the study got abruptly ended. So this also assessed not only just how their mental depression and loneliness was also assessed. We did not give up on the study easily. Later we had the Smart India 2 study, which wanted, as the AI system wanted more number of STDR images, the handheld cameras were used to capture sight-threatening DR images. And after we detected vision-threatening DR, it was noticed that not many, as I rightly told you, were aware and went for eye treatment, possibly because it also involved an expense to go for vision-threatening DR treatment. So Samarth conducted a qualitative analysis to know what were the barriers which prevented them for undergoing treatment towards STDR. So what are the main take-home points which we have seen so far? Even trained unskilled field workers can easily be utilized. They were utilized for the study. The study was not conducted by ophthalmologists. Point-of-care devices like point-of-care HbA1c, handheld cameras, everything could be easily be used for community-based screening. Non-mydriatic handheld cameras were reasonably easy to use. They could yield good images. There were challenges in upload of images whenever there was no internet connection, image quality, grading of images, and suddenly on the top of it, the study had to be abruptly stopped due to COVID. And also what was important that we realized, what not people who were detected and informed that they had vision-threatening DR went and met the ophthalmologist immediately for further treatment. It is essential not to just screen, but we have to close the loop by treating those patients who are detected with sight-threatening retinopathy. We do understand that there is a large burden of diabetes and diabetic retinopathy which needs to be handled, and it's possible only with teamwork. Here what we wanted to see was, I work in a diabetes hospital. where we have the remedy of fundus on phone cameras, which are smartphone based cameras. So Dr. Shobha was interested in seeing is if this model of teleophthalmology actually works. We also do use these cameras in camps whenever we do camps, and we also use it for our home care patients where in our field, when our nurses go to the homes and take fundus photographs. So here what we have 50 branches. Dr. Mohan's Diabetes Specialty Center has 50 branches across India. And here the images are taken, and then we are a team of 7 ophthalmologists at the main center. We look at the fundus images and we send the reports real time, even before the blood test reports, which were taken in the morning, go out to the diabetologist. The eye reports will also be available with the diabetologist. So the diabetologist will know if the person has retinopathy when they see the patient. So if they have retinopathy, they will be advised FFA, OCTs, etc. Those with no retinopathy will be asked to come back after 1 year. So we found that this model was quite effective, and it could detect over 30% retinopathy. This was again in over 60,000 patients in which this study was done. Dr. Shobha initiated this idea, and it was a part of the Ornate India project. So as Dr. Sheena rightly mentioned, just humanly grading all those thousands of images is not going to be practical. So we need an artificial intelligence as a solution. As she rightly showed in her paper, despite the image quality, the retinal images did show that the deep learning model showed a high sensitivity and specificity for even with 2 field images with a high AUC of 0.99. So artificial intelligence is the role when we have a large number of people to be screened for diabetic retinopathy. But is it possible to take retinal photographs for all the 100 million people with diabetes in India? Is it going to be possible? So I think targeted screening, about which Dr. Thomas spoke so well, that is what I'm going to again highlight here. Cystatin C, as he rightly mentioned, can be increased in people with kidney disease. But the study about which he told found that cystatin C outperformed 12 other biomarkers in significantly distinguishing sight-threatening DR from no DR. After this study was done by Shankar Nethralaya, Arvind and group, we did the external validation. Giridhara Institute and we were involved, and we did the external validation. And then we found that sight-threatening DR can easily be detected using cystatin C. So teleophthalmology is useful, use of AI, cystatin C, biomarkers. So what are the practical recommendations? We have to strengthen the NCD clinics. We have to build the capacity of ASHA workers, or we have to build, train and more field workers. Integrate technology like use of AI and teleophthalmology. These models have to be tailored in the sense that focus on high risk group, focus on the states like India, Tamil Nadu and Kerala, which have high diabetes and retinopathy. Increase awareness about vision-threatening DR. The government has to have a national diabetes database, national diabetic retinopathy database. Government has to focus to reduce the cost of treatment for vision-threatening DR. So with the use of innovative technology, point-of-care devices, smartphone cameras, teleophthalmology, AI, novel biomarkers, it is definitely possible to improve DR screening and to reduce avoidable blindness due to diabetes in India. Thanks for your attention. This is our team. This is the Smart India team.
Thank you, Dr. Rajalakshmi, for summing it up. I hope we'll all go through the study again and again and cite it more in our presentations and publications as years go by, and we own up the study even more than that. Thank you very much once again for being part of this instruction course.
Thank you, everyone, for coming to our session. I'd like to request Dr. Thomas to hand over a memento to Dr. Rajalakshmi on behalf of KSOS.